Ashwin, and it's always good to because I happen to be working in a teaching institution for a very long time. In fact, I've dedicated myself to being in a teaching institution where we have a residency program, one of the largest residency programs in India. We have at the AIMS. Total AIMS, we have about 114 residents doing MD, another 50 doing senior residency, which is post MD. They get registrarship. So this is ocular ultrasonography and UBM. And you got to understand that ultrasound is basically 20,000 cycles per second. When the audible sound is inaudible, its frequency is more than 20,000 cycles per second. But the frequencies which you actually use in ophthalmology is much, much more. It's 10 to 20 million cycles per second. So it's totally inaudible. So this is inaudible sound, 20 million hertz or 20 megahertz. On UBM is even more than that. Classical ultrasound which you for the eye in trauma or other cases. Or for the orbit, the UVM is a scan which takes the anterior part of the eye, and you realize how important it is, 35 to 50 million cycles per second. So it penetrates only about 5 millimeters of the anterior segment, so that's got a little bit of a disadvantage. So these are the people who first thought of using sound, and now we're using light for OCT. So all these imaging techniques which are coming in for the eye. And eye is getting more fascinating because of the ocular imaging techniques which have come in for cornea, glaucoma, as well as for the retina in a big way. This last 10 years, you can say this decade is of ocular imaging, and we are improving our imaging so that we can come down to the cellular level to study the various blood flow as well as the cellular details as to see how much of the cells get affected. So we're going to come down to very minute details soon, and we've got adaptive optics coming in which tells you exactly what the cones look like in cases of heredomacular degeneration. So anyway, Baum and Greenwood introduced the B scan, and standardized, I'll just tell you what is standardized ultrasound, which was by Carl Assoinig. So physics is very simple, we don't go into the details of it. It's ultrasonic waves are generated from a piezoelectric crystal which is in a transducer probe which you hold in the hand. It's got a piezoelectric crystal, lead, zirconium, titanate or such like crystal. That's the heart of the ultrasound machine. That vibrates and sends out ultrasonic sound signals, inaudible sound signals from the probe into the eye. It cannot travel through air, so it's got to have a water bath or the eye in contact with the ultrasonic jelly. It's something like the principle of sonar which the submarines used to use way back in World War II or even earlier, that you have sonar which travels, sound waves travel through the sea and detect a submarine, enemy submarine. So same way the water bath is a must, or you have ultrasonic jelly. And this is used all over for gynae surgery, so you know ultrasounds do use. This is converted into electric signal once it's reflected back, the waves. And then signal is reconstructed as an image on a monitor. And you make an evaluation. There are two basic types of scans, the A scan and the B scan. The A is the time amplitude scan, which I'll just show you in the next what it means. B scan is the intensity modulated or the brightness eco-modulated scan. Vector scan is a combination of A and B. And 3D sound, ultrasound is not much of use, but still, we complete the list. This is a A scan. This is amplitude, this is time, along which. So you know what time, you can see the structures coming in, and the lens, and then you got a clear vitreous cavity, and then the retina. So you've got something in between that shows up on the A scan. But the A scan information is one-dimensional, so it doesn't give us much information. So what you want something two-dimensional. This is what you get a two-dimensional. This is the anterior segment. This is a hollow vitreous cavity which has got vitreous jelly, the retina and the orbital fat. And so you can see the orbital fat shows up some echoes. So this is all sound echoes, just like OCT has light which is reflected back. So this is the vector scan which combines A scan, one line of the A scan along with that of B scan. So you can see all those anterior structures, the lens and all do throw up echoes, the iris, lens. But subsequently the vitreous is homogeneous, so it doesn't throw up any echoes, and you get the retina and then the orbit. So 3D is basically creating a three-dimensional picture. So the probe positioning can be transverse, longitudinal, oblique transverse, oblique, longitudinal, axial, and this is how it's being shown, the longitudinal scans. It's placed, if you see these mark, you place it along the longitudinal axis, and you take longitudinal cuts. So you can do longitudinal scans, or you can place the mark on the transverse side and get transverse scans. So this is the way you have to do it, and once the pathology is detected, the clock hour is noted on the transverse scan. The patient is asked to look in the direction of the pathology with the probe exactly perpendicular to the lesion of interest, so that the maximum sound passes through the pathology which you want to see. whether it's in the vitreous or in the retina. So this is to show you a case which has got a detachment. And this is a recent case which I'd just like to tell you. We had a terrorist attack at Pathankot. So being in New Delhi, we had the special forces guy who got injured in a blast by the terrorists, and he was flown to R&R hospital. And we have a little bit of a with the R&R hospital, the AIMS, and so this patient was sent over with multiple corneal lacerations, which was sutured at the base hospital there. But inside, when we saw this 23-year-old commando had just bilateral, you can see the 2 leaves of the retina. So he had a vision of about PR inaccurate, and his eye was sinking. So you feel very bad for such kind of trauma cases, war injuries which are occurring, which are unnecessary. And this young boy, which is hardly 23, is going to be doomed because he's going to be out of the forces and with the one eye, and his other eye is of course okay. But I don't think we can do much for him because the retina is literally torn itself into, and 360 degrees it's torn itself, and it's got retinas. The 2 leaves are hanging up like giant turtle tears incarcerated into the cornea or the anterior structures which have been sutured. So it's a very badly damaged eye, war injury which is now happening in this country very often in the northern side. And we will see probably such more of these injuries. So we have to have people, experts on retina, people who are experts in trauma management. And trauma management will become all along the north, northeast and the northern front. We'll have to have very good trauma centers where we can tackle these young chaps who are, forces guys who get injured. I feel particularly very bad for them. And so this is fresh vitreous hemorrhage. You can see there's a little bit of dots all along. These are brightness or echoes, brightness modulated. And there's no attachment to the disc, and this is the optic nerve. So this is the orbit. So this is a normal pattern. So it shows you a little bit of vitreous hemorrhage. So when you reduce the gain is a decibel, it's in decibels. Normally keep it at 70. It's just like a dial of a music system where you want to reduce the volume or increase. So you put it at about 70. That's a normal standard gain. If it disappears, it's probably just a hemorrhage or some thin membranes. So this is a eye which has got if you see carefully, this has got a elevation over here in the macula. This is actually a submacular bleed. So when we see an area which has got a little elevation, it's got a submacular elevation, that's a patient who's got a neovascular membrane under the retina and it's bled. The bled neovascular membrane has broken through the retina and come into the vitreous. So whenever you see a vitreous hemorrhage, you have to correlate the history. No amount of clinical investigations will give you the information you want or the diagnosis you want. You must have a very good history. So history taking is extremely important. Half your diagnosis comes with the history. So a properly taken history. The other day, one of my residents was standing with me about a week back. There's a lady about 35 years of age. She came, sudden onset diminution of vision. So she had a little bit of disc pallor and vision was very bad. So I just said, did you ask about taking any thiambutal? She said no. I said, ask her. She said, last month she had taken a 8-month course of vithamytol. And suddenly after January when she took it, she started losing vision. The specialist, the medicine guy told her to stop it. And then so we got a VR done. The VR was markedly subnormal. Probably you had a session already on VPs. And the color vision of course was not there. Vision was down to finger counting. So these kind of patients, got to be very careful that if you take a proper history, you've got to take the history of ATT. If a sudden onset diminution of vision occurs, and it's very sudden onset and it's very severe. It's a toxic amblyopia of the worst kind, which is irreversible. So thiamytol, like just going off the topic, it's very important to know. So these are elevated membranes which are bled. So you have to look for that mound. So these are again hemorrhages. So this is a PVD which has occurred. So PVD, where it occurs, the vitreous posterior hyaloid. The posterior hyaloid is normally attached to the retina surface, if you see the anatomy. So the morphology. So once the vitreous posterior hyaloid pulls itself off, you have this empty space, and the hemorrhage is in front. So it's a posterior vitreous detachment. Then this is the case. So this will all be a pictorial lecture so that you can understand better. This is unlike the first RD which you saw, which was the upper one showed a convex surface. This is a membrane pulling it anteriorly. This is a concave detachment. When you have an anteriorly concave detachment, it's got to be with a membrane pulling it. It's got to be a tractional retinal detachment. All anteriorly concave detachments are tractional detachments because the traction pulls it forward, but the rest of the retina tends to stay back. So it creates an anterior concavity. Unlike there's no fluid behind it usually until there's a secondary break, when you call it a combined detachment. So unlike a rhegmatogenous detachment, this is a concave forward. This is the case in which you can see there's a small TRD occurring and there's a membrane which is pulling at it. So this is a small TRD starting to occur with a patient who's diabetic. So you've got to be sure where the traction is. Longitudinal transfer scans have to be done in relation to the optic disc. This is a foreign body over here. This is a foreign body lying literally on the disc. So it's very important from the from the prognostic angle also, because the optic nerve has been injured. You've got to get his VR also done, get his CT scan done, not the MRIs, please. You have to get a CT done, you've got to get ultrasound done, you have to get optic nerve VR check, you got to check the pupillary reactions. And for trauma, you must know the Cohen's classification or the Betts classification. The Betts classification for open glove injuries and closed glove injuries. If you follow that classification, Betts, I'm sure it's there in the session on the other side. So you must know that. So this is a foreign body lying in just on the retina. So this was a case which came about a month back to us at RP Center. The patient was very highly myopic. Said nothing was wrong with him. So we looked at the retina's pathological myopia. We said nothing wrong. So he said just like that, let an ultrasound done. Let's have a look. So we found something elevation over here. So we quickly subjected him to a OCT. We found the posterior pole on a radial scan showed an elevation of the retina, and this is underlying sclera. This is a typically myopic retina which is coning outwards. A normal posterior pole will be like this, posterior sclera. So this is, the retina has pulled itself, also called myopic traction maculopathy. So we have done a lot of surgery there at our place. We get to see a lot of pathological myopia in Delhi. So we found this MTM, what we call it, and it's a well-known entity. It's like Japan in Tokyo, University of Tokyo, they have a myopic clinic because Japan, nearly 30 to 40% of the Japanese population is myopic. So they run a special myopia clinic in the retina services because they have a lot of myopia-induced problems, myopic CNV, myopic traction maculopathy, myopic membranes, myopic RDs, myopic macular hole RDs. So all these are things which they have to be tackled a little differently. So this is another thing which you get a patient who's got, whether it's in the orbit near the muscles or in the vitreous cavity near the retina, can be a pseudotumors like picture with or inflammation in the eye. This can be very dangerous. You have to immediately get an MRI of the head also done to rule out neurocystic sarcosis, as well as this is a scolex inside, heavily outlined. It's high echoes from the, and this is a melanoma which probably Dr. Santosh may be able to tell you better, but the melanoma usually has an elevation and it's got very homogeneous structure. So because it's got a homogeneous structure, if you cut a vector along it, this is the A scan vector, you find the A scan is gradually decreasing in intensity, the spikes. This is known as a large angle kappa. Large angle kappa means if you take an angle from here to here, this is the x-axis, this is the y. This angle is very large because there's a gradual attenuation of the sound. So this is hollowing of the tumor and all those are there, but the large angle kappa is supposed to be very classical, and when we see a melanoma there, of course we refer it on to an oncology colleague, because in RP Center we all have our own subspecialty of interest. If I'm doing retina, I don't touch oncology. So my oncology, ocular oncology is a different different faculty, they go and see it. So then last part of it is the ultrasound biomicroscopy from USG B scan. And this is, as I told you, it's basically, unlike the ultrasound B scan where it's a 10 megahertz probe, this is a 50 megahertz probe to scan the anterior 3 to 4 millimeter. The resolution is also low. So less depth, less resolution as opposed to B scan. So therefore not much is known, but still it's got much of use. It has to have because you're doing the anterior part, you have to have a standoff. That means you have to have a water bath. I told you ultrasound does not travel through air. So you have to have a water, it's a cup, plastic cup. After you put paracaine drops, you hold the lids apart, you put a plastic cup which has bevels. The bevels fit into the lid, under the lid, and then that water bath cup, which is in the concavity of a shape of the anterior curvature of the globe, it fits. The water doesn't leak and we fill it up with BSS. And we then put the probe into the BSS. It has to keep, you can with the syringe keep on filling it up because the water does leak out a little bit. So this is just to tell you a normal, this thing, and Schwalbe's line, Silly sulcus. All this is little anatomical diagrams, but this is the case which we had iris Bombay. There was a severe inflammatory membrane formation over here, the occlusio pupilli, and the whole iris had bowed forward in the iris Bombay form. This was the IOL over here. So the patient had severe detachment and vitreous haze. So we found a lot of anterior PVR. So PVR is membranes and organization of the vitreous in the anterior part of the retina, which is not visible. This anterior PVR tells us that this patient has a very, outcome is very guarded, because this kind of membranes are difficult to peel off because it's not visible. And even if you do depression, vitrectomy and all that, the results are not very good, because the whole membranes engulf the ciliary body and decrease the secretion of the aqueous. The ciliary body, once it doesn't secrete aqueous, the eye goes into a state of hypotony despite oil inside. So this is another recurrent detachment we had recently. We just got we had a lot of posterior PVR, and the patient had stiff retina inferiorly. We got the A scan also done, and the machine which we used, we could get a A scan vector along it, and we found a lot of membrane formation here. So we could study the angle in great detail, the configuration of the iris, and this is an advantage glaucoma also, shallow ACs. And malignant glaucoma is very, very shallow AC. And dislocated lenses, you can have a haptic which is readily anchored over the pars plana. Suppose you have an IOL hanging, you don't know where the haptic is, it's blind. So then you can do a UBM to see where the haptic is actually anchored. People have shown caterpillar hairs also. So study of trauma and all that, so iridiolysis, and then tumors, ciliary body tumors. So the most important limitation of UBM is UBM cannot visualize structures more than 4 millimeters, cannot be performed in presence of an open wound. Unlike B scan is over the closed lids. Even if a trauma patient comes to you in the casualty or wherever you are working, it comes to you, you can do a B scan gently. With the closed lids, you put the ultrasonic jelly and put the probe on the jelly, not on the lid. So then automatically the sound waves will travel through the ultrasonic jelly and you will get the image. But UBM, unfortunately, because you have to put you have to put a cup, an open lid, open the eye, and so you can't do it in perforating injuries or the case like we had from Pathankot. That kind of a case we can't do a UBM because it's freshly sutured and he's come from there. So I think this is all I'd like to share with you.